It's very
Okay.
clear.
Okay. Perfect. Well. First of all, it's great to be able to talk to all of you in Mongolia. We're very honored to be able to talk to all of you and share experiences with you and here from Geneva. It's very exciting for all of us. So we're all very excited over here. So I'm just gonna make a small presentation about basically what the EASL guidelines say about hepatocellular carcinoma. So I just took the EASL slides. I shortened the presentation to stay within the time frame, and it'd be great to discuss these guidelines with you over there. So the guideline panel was composed of the following people, and of course, none of this material is original. It's all really built on the expertise of Franco and all the colleagues working with him in the EASL guidelines. So as a quick background on the incidence of primary liver cancer and the risk factors for primary liver cancer, we all know that the liver cancer is the 5th most common cancer and the 2nd most frequent cause of cancer-related death in the world. It accounts for 7% of all cancers. And within all liver cancers, HCC is, of course, accounting for the vast majority of them, around 90%. And it constitutes, as we all know, a major global health problem. What are the major risk factors for primary liver cancer worldwide? Well, we all know these risk factors depend on a lot of geography. Here in Europe, we mostly have cancer related to alcohol, hepatitis C, less hepatitis B, and of course, there's an emerging, of course, epidemic of NAFLD, of non-alcoholic fatty liver disease. Whereas in Asia, of course, I'm not going to speak for your expertise, but you have maybe more viral hepatitis cases, hepatitis B, C, and in the case of Mongolia, you have a lot of hepatitis delta, of course, and you could see the difference as well, different distribution of risk factors in other places in the world. So what are the key recommendations of the EASL guidelines? Here are the topics I'll briefly touch upon. I apologize in advance for being quite brief, but I'm sure that many of you are already very familiar with this material. So the incidence of HCC, when we discuss epidemiology and risk factors, has been on the rise. And as we all know, cirrhosis is and maybe the most important risk factor for HCC in the case of multiple causes. Although in the case of non-alcoholic fatty liver disease, some epidemiological studies tend to show that maybe not all HCCs in this case arise in the context of cirrhosis, and similarly for hepatitis B. How can we prevent hepatocellular carcinoma? The #1 prevention in the world is universal vaccination against hepatitis B. We should also attempt to prevent progression to cirrhosis and HCC by antiviral therapy, adoption of healthy lifestyle measures, and the EASL guidelines strongly recommend vaccination against hepatitis B, implement various governmental policies, and use antiviral therapies when they are available for hepatitis B, C, and of course, D patients, although we know that the efficacy is much, of course, lower, unfortunately, in these patients. This is taken from a review published by, among other colleagues, myself and some other colleagues in New York, and which basically shows that the pathophysiological progression of HCC goes from normal hepatocyte, subclinical molecular and histological neoplasia, diagnosed first primary HCC, and then recurrence when it happens, and most often in the context of cirrhosis. There are different types of prevention and potential chemoprevention strategies which can be implemented, which are not the subject of today's presentation. An important point, which I'm sure you're all well aware of, is the importance of surveillance in patients at high risk of HCC. EASL guidelines, slightly differently to the AASLD and to the EASL guidelines, recommend surveillance with ultrasound, 6-monthly ultrasound. EASL guidelines do not recommend AFP, although we all know that AFP may be useful in a subset of patients. So EASL guidelines recommend 6-monthly ultrasound in cirrhotic patients with Child-Pugh stage A or B. Also Child-Pugh stage C who are awaiting liver transplantation. Non-cirrhotic hepatitis B patients when they are stratified according to risk. The EASL guidelines use page B classification, which is not really useful in non-Caucasian patients. So I'm sure you all use different ways to stratify HCC risk in non-cirrhotic hepatitis B patients. And whether it's cost-effective or useful to screen F3 patients is still open to discussion. So the EASL guidelines recommend screening for HCC in non-cirrhotic F3 patients based on an individual risk assessment. So in case of a nodule in a cirrhotic liver, this is the algorithm for diagnosis and recall in the cirrhotic liver. Okay, so in case of a mass nodule at imaging, if the mass nodule in the context of a cirrhotic liver is less than 1 centimeter, the guidelines recommend ultrasound screening within 4 months, so maximum 4 months. If it's stable, you go back to ultrasound screening within 4 months. And if there's a growing or changing pattern, they recommend to perform a more advanced imaging with CT or contrast-enhanced MRI. If one of the techniques is positive, again, in the context of cirrhosis, there is one positive technique with HCC imaging hallmarks, essentially wash in the arterial phase and wash out in the delayed phase. They recommend that the diagnosis of HCC can be implemented. And if no, they suggest you use another modality. Again, if one of the modalities is diagnostic, we can confirm HCC. If not, EASL guidelines recommend to perform biopsy. And if biopsy is unclear, to consider rebiopsy, or of course, if the lesion is benign, to stop the recall in at least for this particular lesion. So one point which has to be emphasized is, of course, that these are guidelines are validated in the context of cirrhosis. How you diagnose cirrhosis is a bit open. In Geneva, we tend to biopsy the non-tumoral tissue very often to really document the cirrhosis pathologically, but we can maybe discuss this during the very interesting case presentations you sent us. What are the staging systems for the treatment allocation? So staging systems are really important for prognostic assessment in the management of HCC. And of course, all staging systems are complicated by the coexistence of two deadly diseases, namely cirrhosis, liver disease, and HCC. So EASL guidelines recommend that staging should be based on the prognostic variables for the natural history of HCC and cirrhosis and variables from evidence-based studies. Basically, the EASL guidelines recommend using the BCLC staging system. Maybe we can discuss later on whether you use the same staging system, and we'll come to the definition of the staging system. And also, importantly, that patients should be discussed, as we saw that you do in your center as well, in multidisciplinary teams to fully capture and tailor individualized treatment options. So briefly, here is the BCLC staging system and the treatment strategy. I won't go into it in detail because I'm sure you use some version of this system maybe daily or very often. But briefly, the prognostic stages are divided into 0, where it's single lesion with preserved liver function, which should be amenable to ablation or resection with a very good overall survival. Early stage, essentially patients who are within Milan criteria, who may be candidates for transplantation. So if there's a solitary lesion in optimal surgical candidates, resection should be discussed. If no, transplantation should be considered, especially if the patient is within the Milan criteria. The following stage is an intermediate stage with multinodular unresectable lesions with preserved liver function, conserved performance status. These patients have a slightly worse prognosis of a median survival of 2.5 years. EASL guidelines recommend chemoembolization in these patients. There is probably a lot of space for alternative strategies, whether it's radioembolization. We can discuss this with all my expert colleagues later on. Advanced stage is more a stage which is for the oncologist, or for, as we have here, a joint hepatological and oncological consult, where systemic therapy is more appropriate with a survival of approximately 10 to 12 months. And finally, we all have patients who unfortunately come in the terminal stage who are not transplantable with end-stage liver disease, and unfortunately, you can only offer them best supportive care with a very poor overall survival. A few words on the liver resection. So surgery, when possible, is the mainstay of HCC therapy. It's one of the, along with radiofrequency, is one of the only curative therapy in the context of HCC. So liver resection and transplantation is the first option in patients with early tumors, and maybe extend to other stages after non-surgical tumor downstaging. So the EASL guidelines strongly recommend that surgical resection is a treatment of choice in patients with HCC in the context of a non-cirrhotic liver. In the context of cirrhosis, it's a bit more complicated. Maybe with Dr. Andres, and your team, we can maybe discuss these we can maybe discuss these patients. Indications for resection of HCC and cirrhosis should be based on multi-parametric composite assessment of liver function. So basically, there's a whole host of parameters which have to be discussed. And peri-resection mortality in cirrhotic patients should be less than 3% for the therapy to be considered. Indication and choice of surgical technique depend on tumor size and location. Liver resection in particular is recommended for single HCC of any size, and in particular for tumors of more than 2 centimeters when hepatic function is preserved. In properly trained centers, liver resection should be considered via laparoscopic or minimally invasive approaches. And HCC presenting with 2 or 3 nodules within Milan criteria may be eligible for liver resection depending on performance status, comorbidities, and preservation of liver function. What are contraindications and the follow-up in these patients? So HCC-related macrovascular invasion is a contraindication for liver resection, and intervention on distal portal invasion may deserve investigation within prospectively designed protocols. Neoadjuvant or adjuvant therapies are not recommended, and follow-up after resection with curative intent is recommended, of course, because of high rates of treatable recurrence. What about liver transplantation? So together with NAFLD, NASH, HCC is the fastest growing indication for liver transplantation. It's recommended as a first-line option for HCC within Milan criteria, but unsuitable for resection. Consensus on expanded criteria for liver transplantation has not been reached. So patients outside of Milan criteria may be successfully downstage within Milan criteria, as we often do in our center, and we can also maybe open the discussion later on. Composite criteria are likely to replace conventional criteria for transplant feasibility, and tumor vascular invasion and extrahepatic metastasis are, at the present time, an absolute contraindication for liver transplantation. Pre-transplantation therapy and living donor options. I see that liver transplantation is an option in your center. So liver transplantation candidates with HCC waiting for a cadaveric donor can maintain eligibility with bridging therapy. In liver transplant candidates, so pre-transplant local regional therapies are recommended as a bridge to transplantation. In Europe, contribution of living donation is still marginal, but I see that your center has quite a lot of experience in this, and living donor liver transplantation for HCC remains an option to be explored in selected patients and in experienced centers. A few other slides discuss local ablation and external radiation. Tumor ablation techniques have improved along with the imaging guidance tools required to ensure their successful application. Radiofrequency is the standard of care for patients with BCLC, early tumors, and A tumors not suitable for surgery. In patients with very early stage HCC, radiofrequency ablation in favorable locations can be even adopted as first-line therapy, even in surgical patients. Some studies seem to show equivalent outcome in these patients. Microwave ablation shows promising results. Ethanol injection is an option especially where thermal ablation is not feasible and in small tumors of less than 2 centimeters, and external beam therapy is under current investigation. I'll skip this slide. It just shows the different ways to perform percutaneous ablation. As we discussed, the current standard of care is radiofrequency ablation, which is either with a monopolar or multi-bipolar. What about trans-arterial therapies? So the benefits of trans-arterial chemoembolization in appropriately selected patients have been robustly demonstrated and is recommended for patients with BCLC, stage B, and should be carried out in a selective manner. The use of drug-eluting beads has shown a similar benefit to conventional TACE, and either of the two can be utilized. And a contraindication to TACE, I'm not sure how much you used in your center, is decompensated liver disease, advanced liver or kidney dysfunction, and vascular invasion or extrahepatic spread. Just a quick word on radioembolization, or CERT as we call it, using yttrium 90 or Y90 microspheres. It's currently being investigated in patients BCLC for bridge to transplantation, BCLC-B as a comparison, as an alternative to TACE in selected patients, and BCLC-C in comparison with sorafenib. Current early data show good safety profile and local tumor control. However, for now, it has failed to show overall survival benefits. And we still need to define exactly which patients, subgroup of patients may benefit from radioembolization. It's a very heavy procedure, which is very costly and maybe only useful in selected centers. First-line systemic therapies, which we will discuss later with Dr. Kursler, our referral oncologist here. VEGFR and multi-kinase inhibitors have shown survival benefits in advanced HCC. As a first-line, EASL guidelines recommend sorafenib and lenvatinib. Sorafenib is clearly the standard first line of systemic therapy for HCC, and lenvatinib is non-inferior to sorafenib and is also recommended as a first-line therapy. Second-line systemic therapies, I'll maybe skip this slide just to mention regorafenib, cabozantinib, and possibly nivolumab, which we might discuss during the later discussion. And Professor Negro is pushing me on, so I'm going to soon finish the presentation. Here's an overview of the EASL recommendations and for treatments, and it's basically a summary of all the discussion we've had now. Just a final word on palliative and best supportive care. Management of end-stage disease in BCLC-D patients is only symptomatic, and you all know that paracetamol, or acetaminophen as it's called in the US, can be used up to 3 grams per day for pain of mild intensity. NSAIDs should be avoided, and opiates may be used as needed. What are the future goals of EASL in HCC? So the EASL HCC panel suggested to focus on the following 3 goals: public health policies, and we can maybe discuss this with Professor Negro later about guidelines to prevent, detect, and treat chronic liver disease, appropriate cancer surveillance to detect HCC in a stage amenable to curative treatments, and to link molecular subclasses in clinical trials to therapeutic response and outcome. So I'll skip these unmet needs. We know a lot of these unmet needs, and I'd like to thank you all for your attention. And now we can I'll pass the microphone back to Professor Negro and see if we can continue with the case presentations.
Hello. Unless there are any burning questions, I would suggest, for time constraints, that we proceed to discuss the clinical cases that you sent to us.
Hello. Hello, everyone. Hello. I am Dr. Taiwan Batar, and I'm the chief of HPV surgery department in National Cancer Center, and I prepared 2 cases, and generally we are mostly using NCCN guidelines, and also we are according BCLC classification and also AJCC staging system and Milan criteria, and yeah, mostly we are according NCCN guidelines. And thank you for your presentation. And first case presentation is about this is LDLT, living donor liver transplant case. The recipient was 36 years old, male, and who had HCC. HCC downstaged into Milan criteria, within Milan criteria. And that patient had also HPV and HDV related advanced liver cirrhosis with the child B, and also severe portal hypertension. Okay, next slide, please. Okay, he was diagnosed his HCC in 1 year ago, and he underwent RFA, radiofrequency ablation. Next slide. And in the March 2018, the laboratory tests there is the low PLT count. Next slide. Okay. There has also liver failure. Okay, and he underwent antiviral treatment with tenofovir. Okay, because of HPV and HDV activation. And in the radiology exam, there was a HCC in segment 7 of the liver with liver cirrhosis with multiple dysplastic nodules also. And there was also splenomegaly due to portal hypertension. And that now you see the preoperative CT scan. There was a small solid small HCC in the segment 7 with two HCCs, small HCCs with Milan, with the arterial enhancement with the washout sign. Okay, and we discussed in our HPB surgery meeting. We discussed liver transplant, and we performed in May of this year. We performed RFA, living donor liver transplant surgery, and the tumors was downstaged. Okay, next slide. In last slides, there was RFA scars you saw, and preoperative liver function tests were like this. Okay, in last month, we performed the living donor liver transplant for this patient. Okay. Okay, that's it. Thank you very much. Okay, do you have any question?
Okay, thank you for this presentation. I will certainly give the honor to Dr. Gossans maybe to comment on, or in turns we can hear the opinion of the surgeon, of our oncologist.
Thank you for this very interesting presentation. I'll quickly leave our resident surgeon, Dr. Andres, to mention, but it's an interesting case of a patient who had 3 lesions clearly within Milan criteria, and who was lucky enough to undergo early living donor liver transplantation. So it's congratulations for this very interesting case. Maybe I'll.
Hello, we were just wondering, we were a little bit puzzled by the fact that the bilirubin was, only the direct bilirubin was increased. What is your hypothesis for that? Do you have any any hypothesis why only the direct bilirubin was increased? We were wondering here.
Yeah, it seemed like the liver function was not bad. The coagulation, the prothrombin was preserved. And it just seemed that the bilirubin was quite high at 60 micromoles. It was direct bilirubin. And we were a bit, although we do see it, of course, in cirrhotic patients, it was interesting.
Do you have any comments for this? Preoperatively, we checked it by contrast-enhanced CT scan and also with ultrasonography. There was no dilatation of intrahepatic bile ducts. And there was liver cirrhosis with 2 small HCCs. And for liver surgery, liver resection, impossible because of we're afraid of liver post-op liver failure. And our liver transplant decision was, I think, it's right decision for this patient, because patient is a very young guy. Patient age is 36 years old, and the patient had a liver cirrhosis, macronodular liver cirrhosis with liver failure. The child Pew classification was B, and he had also portal hypertension and low platelet count, and liver resection was very high risk. There was a very high risk of liver resection, and liver transplant is, I think, good choice.
So on the direct bilirubin going up, this is something we actually observe in the HPV and HTV patients. The cirrhosis of these patients does not seem to always behave the same. So, for example, in a normal patient, we would usually see albumin actually going down and kind of a normal way of going decompensation, but especially these young people with B and D co-infection, superinfection, they are this chronic B and D patients, what they presented is either they are coming very early on having a high portal hypertension and splenomegaly, and then the PLT going down, and then the bilirubin, not the total bilirubin, but the direct bilirubin going up. We don't really have very strong evidence why that happens. We have basically 2 explanations. One is that, at least we see it in Mongolia quite a bit, so we think that there might be something genetical thing in there. The other thing is there might be something within the pathology, something happens that only affects the certain metabolism of it. One thing why we considered that was that sometimes we see patients that with the B and D, they would have B and D and then actually spontaneously cleared, but then they would still stay with the direct bilirubin up. And also we see quite a lot of the patients, we see direct bilirubin is slightly increased without having any kind of liver disease. So that's why we have these 2 theories. It might be something genetics and it might be something to do with the pathology induced by the D infection. But we don't have any hard evidence, so it's just an assumption that we are making. So we see these things, we don't see this one so much in the chronic C or other cirrhotic patients. So this is something we observe. I think we have to collect a lot more data and then really look into that. I think that would be an interesting study, I think.
Okay, I may ask a final comment from the surgeon here. Dr. Andres?
Yes, hi. So thank you very much for this very nice presentation indeed. So you manage the patient according exactly to the EASL guidelines. So overall, there is no real comment. I think that it's clear that for a young patient with multiple HCC, the best option, if you can have it, is transplantation. My only question would be about the bridging therapy until the transplantation. In Europe, most of our transplants are from cadaveric donors. So we have a waiting time, which is pretty important. So in Geneva, for example, we have a 1 year waiting time period before patient can be transplanted. So we use, as you did, bridging therapy, RFA or chemo embolization. In your case, because you used a living donor, my only question would be if you can transplant the patient very soon, do you think if there is any advantage of performing a bridging therapy finally, because your waiting time can be very short?
Sure, I agree. I agree with your opinion. Yeah, and you know, we are according also Makati 3. You know, Makati 3. The algorithm for about the management of HCC. It's a Japanese algorithm. Yeah.
So it's something that we don't use. So do you do transplantation from cadaveric donors in Mongolia?
No, not it. In first central. No. Excuse me. Okay. In our National Cancer Center, Mongolia, we are just starting liver transplant program, and we are now performed only 5 cases with the living donor. But in other hospital in Mongolia, it's a first central hospital. Mongolia was performed about 50 cases, and one of them was cadaveric, I heard.
It's additional information about the liver transplantation in Mongolia. The liver transplantation program in Mongolia started 11 years ago, and it started the first liver transplantation 7 years ago with Korean doctors. We already performed about 55 cases. The success, thorough success about 95%. 95%. Also, we only one case we done cadaveric donors. 53 is living donor liver transplantation. Among them, about 17 cases with liver cancers. Now program is going very successfully. Yeah. Also, our government is covered liver transplantation cost since 2019.
Okay, I have another case. There is just HCC with liver resection case. And 3 times liver resection was performed in National Cancer Center, Mongolia. And the patient has 60 years old female. And the clinical diagnosis status post wedge resection, FOF-A and segment 3 in 2018. Due to recurrent de novo multifocal HCCs, and second status post wedge resection from segment 8 in 2015 due to recurrent HCC, and also status post wedge resection from segment 5 and 6 and segment 1 also. and with the cholecystectomy in 2009 due to primary multifocal HCCs of the liver, and also she had HCV and HPV related liver cirrhosis with the child A. And first management was non-anatomical wedge resections from segment 5 and 6, 7, segment 1 in 2009, because why we performed non-anatomical wedge resection? Because of we had need to preserve liver volume, remnant liver. And next slide, please. And we performed 3 times surgery for this patient. And for the follow-up exams was performed with ultrasonography and alpha fetoprotein level. We was follow-up. Okay, there was CT scans and next slide. The preoperative AFP level was high, and post-op AFP level was decreasing. But in last management was also surgically we decided. Okay. Okay, that's it. Thank you very much.
Thank you very much for this, again, very, very interesting case, which I'm sure will stimulate the discussion. So this is Nicholas again from the hepatology side. I just have two short questions. The first question, I saw in the previous patient, I believe you used FibroScan stage for background liver fibrosis. Is this your traditional practice? Are there some situations where you perform biopsy of the non-tumoral liver to diagnose or to confirm cirrhosis? And my second question is, in this BNC infected patient, did the patient have access to antiviral therapy, and how is the response to the antiviral therapy? Thanks again for the very interesting case.
Every recurrences we was doing liver resections, and for interventional radiological approaches didn't do that case. Okay, because the HCC characters was hypervascular HCCs, and the patient was choosing surgery. Okay, we always recommend TACE and RFAs, but the patient was choosing resection, liver resection.
Can I just have 2 comments on that? So in Mongolia, we don't do so much biopsy. So biopsy is only in the...
We are always doing biopsies pre-operative. Always.
Everyone?
Yeah, not for everyone. Because the HCC, for this patient, there is no need to biopsy, because for the contrast enhanced CT scan, there was a classical sign of HCCs, because there was AFP level was high, and also in the CT there was in the arterial phase there was arterial enhancement, In the late phase, there was washout sign, and there was no need to biopsy because once there was no need to biopsy. Okay. For this patient, she had hepatitis B and C, dual viral hepatitis, and the HCV RNA and HBV DNA count was 0, non-active hepatitis viruses. No. She didn't receive the antiviral treatment.
Okay.
But she had, she was cirrhotic.
So just a little bit of an explanation on that. The FibroScan is not routinely done. I think one of the things is that FibroScan is not covered by the health insurance. So it's basically some patients could afford it, some patients could not, and some patients don't have access to the FibroScan. So it's not everyone is staged by the FibroScan. And the biopsy-wise, as far as I know, I'm not a cancer doctor. I'm not an oncologist. I'm a gastroenterologist myself. But as far as what I see in my clinic is that not everyone is getting biopsy. Routinely what's done is the APRE score. But what we know also is that for hepatitis B and delta patients, the FibroScan or the APRE score, it doesn't always work reliably. So this is one issue that we usually have. So this is something a lot of the times we basically based on our clinical observations to the treatment and to the follow-up. So this is, we are in a country that has very varying kind of equipments, varying availability of techniques across the Mongolia. So if a person comes from countryside, they wouldn't have any of these kind of tests. So let me proceed with, since the time is quite important, let's proceed with the third case. So this is a patient who is 58 years old, has chronic hepatitis C history. Also there's a suspected HCC, and then patients referred to the National Cancer Center. There's not a lot of other comorbidities except the having diabetes. And currently on insulin, and other than that, there's currently basically have a little bit of yellowish skin, has enlarged the spleen. Other than that, there's no other significant findings. In terms of the lab findings, anti-HCV positive, viral load is also positive, PLT is decreased, and then the ALT/AST and total bilirubin has increased, and the diabetes, the glucose is not very well controlled. Also creatine, BUN is also increased. So the child view B, but since there was no INR, it's not very precise. MELD score possibly around 14 to 16. As said earlier, there's no INR, so it's difficult to say. MDCT, the MDCT was done with contrast, and the conclusion is that there's a heterodense infiltrative mass in the posterior segment. There's also an abscess formation. So HCC needs to be, it might be that HCC is associated with the liver abscess. Chronic pancreatitis also has gallstones, and splenomegaly was diagnosed, was seen. So it's quite big size yield margin area in the S7 and 8, but there was no lymph node enlargement. Spleen is 14.8 and 8.9. So these are the images in the arterial phase. This is the portal phase. So the diagnosis is currently that we have put liver cirrhosis due to the chronic hepatitis C, child few mass, and poorly controlled diabetes with the diabetic neuropathy. So on this one, basically this person, we wanted to present it because we would like to start a dialogue. Basically, we wanted to open up a discussion on about the hepatitis C treatment and its connection with the liver cancer. So what we, as you know, that in Mongolia we are conducting out this large treatments for the hepatitis C. Obviously, having this wonderful drug that cures the hepatitis C, we are treating a lot of people. So in the last 2 years, we have treated almost more than 30,000 people. So this is sometimes leading to the discussion within our professional colleagues is that, okay, when someone has hepatitis C alone, obviously you have to treat, and then our guideline is also on that, so we are treating them. But then some of the people who are already having liver cirrhosis, they are later on developing into liver cancer. So the question is these people are having liver cancer because of the treatment, or is it so probably I have to put the question a little bit differently. Does the mass treatment is causing a lot of the hepatitis, a lot of the liver cancer, or is it the other way around? Because we are treating a lot of the people who have cirrhosis, and then they are already kind of on the way to having liver cancer. So this is one of the discussions we would like to have with you. The other thing is that when do we treat people with liver cancer with the combined hepatitis C? For example, on this person, do we treat the hepatitis C or not? When is it better to treat, and when is it before the treatment of HCC or after the treatment of HCC? What are your opinion on this matter?
Well, as you know, this topic is still open to debate. Well, as you know, this topic is still open to debate. There is no final consensus on what to do. I believe we need to gather more data. It will be very difficult to have all stratifications, but our attitude in Geneva is to treat patients against hepatitis C anyway. I would like also to draw your attention anyway to the fact that this patient had diabetes. So the liver disorder was not caused only by hepatitis C virus, but also by the metabolic syndrome. So we may eliminate one reason for promoting oncogenesis. You can't really control everything. So I think each case has to be considered as on a case-by-case ratio on a single cases, I think. But our attitude is to treat patients with hepatitis C. The idea is behind this is that we don't really see, I mean, based on the data, we don't see an increase in the risk of recurrence of the cancer. What is debated currently is whether there is indeed a decrease or not. That's debatable, but certainly there is not an increase. So I don't see the point of withdrawing treatment from these patients.
So what you are saying is basically hepatitis C patients treating is very important, whether it's with HCC or without HCC.
Oh yes, I would definitely say so anyway. Clearly, the treatment of the cancer proceeds independently of this. Of course, you must be take into consideration is the risk of drug-drug interactions, but that's a different story. I let maybe Dr. Kessler to say something about it.
So I'm a medical oncologist, and with my colleague, Dr. Gusens, we have opened a multidisciplinary consultation where we see together the patients. Our attitude towards this patient is if we can offer a treatment that will at least stabilize the HCC, we usually combine it with the treatment of the hepatitis C virus. We have done so successfully recently with one patient, and hopefully we will just continue. So I agree with Professor Negro on what he has said. Currently, there is still some debates, but our attitude is if we can offer the treatments, and if we are, we will do it.
No, like leukocytosis. I think I saw on the CT scan there was. I don't think about abscess, not purulent HCC. I think on the CT scan shows infiltrative HCC with central necrosis, and also I would like to recommend for this patient best supportive care with DAA treatment. Yeah, best supportive care, palliative care, and no surgery. And the tumor, the alpha fetoprotein level is very high, and it means very advanced HCC, and there has no arterial enhancement, and it means impossible to do transarterial chemoembolization. Or maybe, how about, what do you think about transarterial radioembolization with the Nexavar, also sorafenib?
Yes, thank you for asking that question. We were actually discussing it while you were presenting the case. We agreed that for a patient like this one, the management in Geneva will probably involve first the radioembolization with this big lesion. That is, despite being big, that's unique lesions. Although we also discussed the possibility to do some stereotaxic radiotherapy, external radiotherapy. We have some good cases here where the lesions were either symptomatic or they were too big, and the radiotherapy offered a good local control. It is not entirely satisfactory, but it can provide relief for symptoms and at least
for the time being, a control of the disease. As per the systemic treatment, indeed, I mean, it is always possible, or it is possible in this case, to start on the systemic treatment, and I will, as it is advised in the guidelines, to start with the sorafenib. I would like to remind everybody that it has been tested mainly on the child score A, and you can go up to B7, but I would be extremely careful to start this treatment without watching extremely carefully the patient, because if they decompensate the cirrhosis, it's very easy to go from B7 to B9, and then obviously the treatment becomes, in fact, quite toxic. So in this case, because it's probably child A, sorafenib is an option. It will not be my favorite option at this stage. I would favor local treatment, but it is an option.
Okay, thank you very much.
Well, what's your personal opinion about HCC rate, occurrence rate, incidence rate with the DAA treated population. So in Mongolia, there a little bit of debate around if the DAA, treating the patients with DAA aggressively causing a lot of HCC. So what do you personally think about that?
Well, you have to consider that these are quite advanced patients. So after all, it's not so surprising that they do have recurrences. And this has been very well described in the literature. I mean, these patients, if they have a so-called curative treatment, may have a recurrence rate between 20 and 30%. And the recurrence rate, which has been reported in several studies, also including those from Italy and Spain, is sometimes around the same rate. The general opinion we have in Geneva is that the recurrence rate is not increased. So may do some good to these patients, at least avoiding progression to decompensation. And these recurrence tumors, they've been also successfully treated on a second line. Do you have your experience? So, from what I understand, is more cautious. Is that right?
Yes, it is.
Did you experience explosive recurrences after treatment with DAA, involving, for example, the whole right lobe or things like that?
I can't say about this topic because we need to do study. Because yeah, and I saw some of patients post DAA HCC. Yeah, maybe we need to do study, clinical study about DAA treatment related HCC. Yeah, maybe HCC recurrence and also post DAA HCC incidence. We need to study this.
Yeah, but you may understand that you may have actually early recurrences because very likely these small tumors were already present when we started DAA. The question we should address in the future studies, of course, if number of patients allow, because actually we are running out of patients in Geneva, for example, very quickly, is whether the DAA treatment may accelerate the recurrence. And I believe this is not clearly proven by the data, to tell you the truth.
I had some patients who underwent liver surgeries and with the HCC, and after liver resection, the patients who had received DAA, the tumor HCC recurrence was occurred. And I think post DAA HCC recurrence maybe it's maybe high. We need to do study, yeah, about this topic.
I have a recommendation about it. Just months ago, we collected some data, the treatment results. But there is not high recurrence after the. It is very low percent, about this, maybe 1.2% among all treated patients in Mongolia.
So I mean, probably, are you running a prospective study on this point?
Yeah. Yeah, we have a very small study that showed basically it's by the staging, obviously it increases. With the cirrhotic stage, it increases the HCC occurrence, but it's the whether you use DAA or not. Actually, The occurrence of HCC is same. With the treatment, actually, they have more life quality betterment. So actually, it's actually more towards doing the more treatment was actually a lot more beneficial to the patients.
Okay.
But I think we need a little bit bigger study.
Okay. I think I'm sorry, but we are probably running out of time. We have other, unfortunately, meetings today. If there are any other final burning questions, we are welcome. Maybe we can also exchange email messages, maybe, to discuss further these cases and other aspects of the HCC management. Any other final comments from Mongolia?
We would like to thank you, really taking out time to help us. It was really wonderful lecture. Thanks a lot. And hopefully, when we have time, we can still email you. That would be really wonderful.
Absolutely. I think we're certainly planning a second teleconference, very likely with Dr. Markus Kornberg from Hanover. I believe this should be the management of hepatitis B and Delta. This will be discussed in the next few days with the EASL office representative, especially with Ms. Munia Haddad, who's been organizing the connection today.
Thanks. Sounds very good. So let's continue offline, and then we exchange emails. And thanks a lot, all four of you, taking time out and helping us out. And thank you. It was really a pleasure to listen to you guys. Thanks a lot.
It was very nice, actually, exchange of ideas, of data. I'm very pleased that this worked fine. I want to thank my colleagues here in Geneva. I want to thank you also for preparing these cases for us today, and also for being so numerous in the room. I was very pleased to see how many people participated enthusiastically to this event. On behalf of EASL, thank you again, and we'll keep in touch for the next teleconference very soon.
Okay, thanks. Thank you. Have a good day.